antibiotics, the STD is gone, and the viral load drops. So there is a direct synergy or connection between having STDs and HIV. So if you have STDs, you have to get treated for STDs, even your viral load goes down. So STDs also play a major role in the viral transmission. So the 40% chance, you're not protected. But if you have safe sex practice, and if you know for sure the status of your partner and yourself, okay, and there wouldn't be a need to circumcise, but under the context of prevention and protection, having safe sex, and just to be on the safe side, if you wish to be circumcised, it's a good option. But again, you need to have protected sex. That it's a double-edged sword. It's not that you're circumcised and you're fully safe. No, it's still there are routes of transmission, and people who are circumcised have got it. There have been studies which have been done. People who are circumcised have got it, especially before it starts to heal and things of that nature. So it's not that it is 100% safe. Now here we are entering into more into the details of the subject. Here what we are seeing is the red line is the viral load. You can see the red line. Initially when a person is infected, the viral load peaks. Why does the viral load peak? What is the reason? Why is it that the viral load is increased? Your immune system has not started its functioning yet. It hasn't started. That is why even in the very beginning I was telling you, that is the problem. If someone can come up with the idea of bringing this viral load having started and peaking there and then going down, you can see around 3 weeks has gone. If somebody in this world can bring this point from here to here, nobody was going to get HIV. It was not going to happen, because the cytotoxic T cell response or the immune cell response or the CD4 response for the commander to signal the CD4 T helper cells, for the commander, which is the CD4 T helper cell, for the T helper cell to command the cytotoxic T cell and also give instructions to the B cell, takes quite a bit of time. This is the adaptive immune system. So for the signaling mechanism to take place, it takes quite a while. If someone can you will get a Nobel Prize if you can shift from this point up to this point. That's it. But that is what, that's how the immune response is slow. Even if you have a viral infection, it takes quite a while. So anyway, what happens here is the viral load peaks, no immune response. And since the viral load is peaking up, your CD4 count keeps dropping down and down and down. And then your immune response picks up, which is it? CD8 cytotoxic T cell response. It picks up. This is more like a computer. I've just put an image there so that you know, just like a computer, you click and then this and this. For it to start, it takes a while. So that's just an analogy I'm just giving you there. And then what happens? After that, your CD4 count starts to go up, but it doesn't go back to where it was before. That is the problem. That is another problem. For example, see, for a person, just in general, you are supposed to have, a CD4 count in the range of 500 to 1,600 cells per microliter of blood. That is the usual range of CD4. And then, supposing if this was 1,200, it has dropped, but it would again not go back to the 1,200, it might get stuck somewhere around 800. And then, each year, 60 to 90 cells per microliter of blood is being lost consistently every year. So there is a constant decline of your immune system. I'm not talking of antiviral therapy here. You haven't started assuming the person is not on ARVs or whatever. We're just seeing the stages of infection. Then it keeps dropping. And now here you see a straight line. This is what we call it as a set point. If my cytotoxic T cell response is not good, this viral load set point could be somewhere there on top. But if it is here, which means the cytotoxic T cell response is good, or if it is still lower, it is good. This is what is found in some people who are elite controllers. These are long-term non-progressors. People who don't progress to AIDS even after 20 years because of the robust immune response of the CTL, cytotoxic T cell response, will bring this line to somewhere down there. Okay? So what happens? This is what is called as a set point. So a person will reach a set point in say around 6 months after infection. So suppose if I am infected today, say in around 6 to 8 months I can know my set point. So for that you need to do the viral load test. So these are some of the things we need to partner, network and work together so that we try and talk with the stakeholders. We bring in this viral load test so that people know the disease progression. See, CD4 can only tell you how your immune system is working. But how virologically, what is your system doing? You can know only through the set point. Okay, so now then afterwards, there is a switching here taking place somewhere here. This crossing over point, you find that again the viral load goes up. For those who are studying HIV and AIDS, immunology or virology about the disease, we call this as class switching from CCR5 to CXCR4. Remember in the very beginning, I told you, the virus requires 2 doses to enter. Okay, the CD4 molecule is there. This is the CCR5 is there. It enters. This is the system which exists in people who are newly infected. Over a period of time, this CCR5 doesn't work. There is another kind of a receptor, surface receptor. This is called as CXCR4. This is the one which gets it. And the disease progression is very rapid and people, progress disease when you have the CXCR4. So the initial door of entry is the CCR5 and the next door of entry is the CXCR4. This is what we call it as non-syncytia to syncytia. We'll see what is non-syncytia and syncytia later. But anyway, in putting it in a different terms in immunology, we call this as class switching. A person becomes entropic to T-tropic, which means, if you have noticed, I've been always talking about the cytotoxic T cell response, CTL response. It now changes from the CTL response to the antibody response. Antibodies are not very good in targeting viruses. The reason is very simple. I told you in the very beginning, on the outside is GP120, which is glycoprotein 120. This GP120 is what suppose this is the antibody, is what it sees, it binds to it. But it mutates, it changes. Then again it binds. You have to make a different set of antibodies. So you have to make a different set of antibodies. Then again the virus mutates. Again a different set of antibodies. The virus mutates, a different set of antibodies. So it's more like a cat and mouse game. Your immune system is doing a great job in making antibodies. It's doing the CTL response is good. Everything is good. But then it's not enough to catch up with the rapid replicating virus. And then finally, what you see is the viremia, or the viral load keeps going up. Meaning, assuming no heart is, meaning you haven't started heart, which is the antiviral therapy. Now, what are the different phases of infection? We see the initial infection. Okay, this one is the acute infection. We talked about fever, swelling of the lymph nodes, and flu-like symptoms. All these things they do set in during the initial phase of infection. Sore throat, that is another. But now some people say, I had sore throat today and tomorrow I had swelling of, after 1 week. No, it doesn't happen like that. All these occur at the same time. That is why we call it as a syndrome. A syndrome is a collection of manifestation of illnesses or diseases, whatever you call them. They all occur at the same time. And then after that, it goes into the asymptomatic phase, which means no symptoms happening. And then you start to get what is lymphadenopathy, which is infections in the lymph nodes, wasting syndrome, and then loss of weight, neurological disorders, and then the early immune failure, which is the herpes, which you start getting the varicella zoster, shingles, candida, hairy leukoplakia, caused by EBV, which is Epstein-Barr virus, and then Frank-AIDS, pneumonia, pneumocystis carinii, pneumonia Kaposi sarcoma, and other kind of fungal and bacterial infections and protozoal infections, they take over. Simply because your immune system is compromised. Meaning, you have to initiate highly active antiretroviral therapy at the right time. And this is just another addition to what was there. Based on the CD4 cell count, you see 400 this, tuberculosis, oral candida, pneumocystis carinii, esophageal candidiasis, and then toxoplasmosis. It affects the brain and cryptococcal infections and all these cytomegalovirus. This is another type of herpes virus, cytomegalovirus. It affects your retina, it affects your gut, and that's how it goes on then Kaposi sarcoma, and when your immune system is compromised. And this is just another graphic image which shows very clearly, based on different regions of your body, what are the different infections, the fungal infections, the pneumocystis carini, where does it affect the lungs, histoplasmosis, bacterial diseases, salmonella, and here we see cancers in the cervix, lymphomas of the brain, B-cell lymphoma, and protozoal toxoplasmosis. So that is why people with the toxoplasmosis can also be found in fecal matters of cats and dogs, in sand, and that kind of. So handling such things should be avoided for people who are HIV positive and whose immune system is compromised at very low CD4 count. And this is a nice diagram because it depicts each infection and the regions where it infects. And this is to do with the tuberculosis. We all know that for a person who is immunocompromised, whose immune system is compromised, the chances of risk of TB increases. You can see it's increasing. So after initiation of antiviral therapy, antiretroviral therapy, the chance of TB goes down. It's just a graph showing you the relationship between HIV and TB. So in short, when you start on antiviral therapy, your risk of contracting TB also declines. And this is what we earlier talked about, the acute infections. You can see a fever, sore throat, skin rash, swelling of lip. These are some of the classic symptoms. It's not that something else. Some people may not even have these kind of symptoms. Some people might just go away like that. Some people can have these kind of symptoms. And there is no ground rules that you can have or you can't have. But usually, see, we are talking about situations, majority of the cases, according to experiences of a lot of healthcare providers, data which have been collected, these are the classic symptoms. And they don't come, as I told you repeatedly, they don't come one by one. They all happen almost around the same time. And but this is just a general, you can see lymphadenopathy, swelling of the lymph nodes, rash, and vomiting, nausea, but these are quite minor, but majority, this is the kind of thing they see. And the median time is around 2 to 3 weeks. That's the median time for acute retroviral syndrome. This is acute infections or seroconversion symptoms. This is another model of the same thing. You are exposed, onset of symptoms, you test antibody negative. Remember in the previous slides I was telling you, the immune response takes 2 to 3 weeks. That is why you are still antibody negative. Because you see the tests that we do, we look for antibodies. We don't look for directly for the virus. But if you do a PCR RNA test, which is a viral load test, on a HIV positive person who is newly infected, say in less than a week, you could start to see the viral load being very high. But those tests are very expensive and they are not used for routine screening. They are mainly used as diagnostic tests. And of course, if you have the money and if you have all the resources, you can do the PCR RNA, which is a quantitative PCR RNA test. It quantifies, it tells you exactly the RNA copies, which is the viral load. So that is the point. Then this phase is called an eclipse phase, and this is the mononucleus. You might go into your healthcare provider and say you've got a mono, which means these kind of acute symptoms. And then you see the viremia peaking up. 1 to 5 million viral copies per milliliter. We are not talking the whole body. Just a milliliter of blood could carry that big number of copies of virus. So in the entire human body, we are talking of mind-boggling numbers of 10 billion copies of virus particles or more. And then afterwards everything is resolved. It goes into the phase which is called asymptomatic, which means no symptoms happening, and then you get what is called a set point. Remember I was talking to you about the set point. Then the person remains with the set point for a prolonged period of time. Maybe 5 years, 6 years, 7 years, he might be on the set point, and then the viral load will again shoot up, assuming no intervention of antiviral therapy. And then this viral set point, your T cell again comes back to, not to the original levels, it comes back, it gains, regains. But then again, I remember I told you, your T cell count keeps declining each year by 60 to 90 cells per microliter of blood. So your CD4 cell count keeps dropping and dropping and dropping. And then the eventuality is there. So this is just another slide to show you the percentage of.
Oh, sorry, good afternoon again. Yeah, I was just trying to inquire. The lights.
Slide tells you some of the kind of seroconversion illnesses that you can get, say around 2 to 3 weeks after initial infection. Fever 80 to 90%, fatigue 70 to 90, rash 40 to 80, headache and all that. But as I showed you in the previous slide, according to experiences, mainly rash, fever, swelling of the lymph nodes and sore throat. This is the kind of thing that is commonly encountered. But you might not even get these seroconversion illnesses as well. There is a high chance that you even don't have them. Now here, we are seeing two graphs here. And there was someone who was even asking, I mean, we were even talking about this previously, what is the chances of you contracting the virus at different point of time? For example, you see here, this big graph, the one here, this is for a patient who is having a very high viral load. No immune response, nothing. The viremia is very high. The cytotoxic T cell response hasn't set in. You can see the probability chance is 1 in 130. So, not 1 in 130, so 1 in 30. Out of 30, the probability is 1. The chances are very high. But now you can see this graph here, which has got a higher, which doesn't have the higher viral load at the peak, as in this case. It's peak to a lower viral load. And you can see the probability is 1 in 200. So the viral load of the person makes a lot of difference. But now this is during the initial phase of infection, meaning 2 to 3 weeks after initial infection. And after that, it takes almost a straight line. What is the straight line? Is a set point. Remember we talked about the set point? It sets more like a concrete. It has set to that level. So if you see this guy who has got the high viremia has got a higher set point. And this guy who has got a lower viremia during the acute phase has got a lower set point. So now seeing the probability here, 1 in 1000 is this guy here. You see the probability, the chances of getting is still less now, 1 in 1000. And see this guy here, he's got a lower set point, 1 in 10,000. And then the climax happens, which is, if no intervention of antiviral therapy, it goes up, it shoots up again and again. So you see for the guy, for example, in this phase, very high, 1 in 50. For the guy with the lower set point, it was going to start picking up somewhere after more number of years, and he could be still in 1 in 1000 range. So what we see here is the immune response for each individual is different. You see, my cytotoxic T cell response would be more robust than the others. But here there is a bit of it's just a guesswork. For people who seroconvert from negative to positive, but don't experience this acute infection, could be in this category. It's not a guarantee, meaning the set point could be lower. And they don't get this high peak over here. People who seroconvert with severe illness, almost taking them to the hospital and taking them for so many other medications and still not getting back on their feet, could be in this category of a higher viral load during the acute phase and a higher set point. There is no ground rules for this, but that is what some studies suggest. And this is the different type of testing methods that you can adopt. See, the earliest detection is the RNA, PCR RNA. HIV RNA, which is the PCR test, PCR RNA test, polymerase chain reaction. You can know your viral load. You can know your status, so to say, to simply put it, at a very early number of days, as low as around 10 to 11 days, you can start to detect, and then you can see the plasma RNA. So if you have the money and the resources, in some countries and some laboratories, they do the PCR RNA test if somebody has put themselves at risk of HIV. But here again, there is a problem. For example, I am HIV negative. You do the PCR RNA test, you can still get some readings. It can show what is called as a false positive. So unless the viral load is more than 10,000 copies, these are the gold standards, is when you can suspect that person to have contracted the virus. But less than 10,000 copies, the chances are slim, you see. So in short, if I'm negative and my brother is negative and my sister is negative, we test for all of us, we would all test positive on the PCR RNA, but the copies could be less than 10,000 copies. That's the point. We could all test. So that is why PCR RNA test should not be used as a screening test. But in resourceful settings and people who have got money and who have put themselves at risk at HIV, they could test positive more than 10,000 copies, maybe 1,000,000 copies, more than that. And those are signs of seroconversion, which means that person could be positive. So in short, what I'm trying to say is you don't do a PCR RNA test just on anybody, even if they're seroconverted. One is the cost, one is the false positive. Anyway. Then we can do another one. Where is this? The antibody test comes in a bit later, around 2 to 3 weeks. I'm sorry, detectable antibodies you can start to detect in around 3 weeks, but the gold standard is 3 months. And of course you can start to get, you can be satisfied, like if you have taken an antibody test in 8 weeks, possibly you are still negative if you happen to be negative. You don't need to worry much, but still you know the gold standard is 3 months. And then this is another very interesting test, which is an antigen antibody testing. Can you see the P24? P24 is one of the capsid proteins in the virus. If you have seen long back as we were seeing the viral replication, P24 is one of the capsid proteins. Looking for the P24, this is a rapid test. We can try to implement this even in Zambia. If you can do it, it will be wonderful because it is called as a 21-day test. So in 21 days you can know your HIV positive or HIV negative. You don't need to wait for the 3-month window period. So this is a very short window period test. It is done even in India, it is done in many countries, very cheap. It's a rapid test. You just need a 1 drop of blood and wait for 3 minutes and you're through. So, and it also has another marker there, which is an antibody. So if you skip the P24 antigen, it will still pick up the antibodies. But that will appear maybe after around close to 6 to 8 weeks. So what I'm trying to say is, by knowing the person's status much earlier, your mental issues could be resolved. You could know the status of the person and take certain precautionary measures. Maybe you may not want to have unprotected sex. So there are several social factors and several issues relating to social, on the context of social issues, which can be sorted out, Meaning, if you know your status much earlier, are you not going to be better off or are you not going to be happier? It's better, isn't it, if you know our status much earlier. So, so that you can take certain corrective measures, so that you use protected sex or do such things. So what I'm trying to say is, there is a facility in place which is called as a P24 antigen testing. And it also comes with the antibody, so it's a double. You skip the antigen, you pick up the antibody. So this is more like looking for a piece of the virus itself. It's called as a P24 antigen antibody testing. Probably if we can try to, talk with stakeholders and try to implement this, it's going to make a lot of changes in our testing methodology. And this one, why I introduced this slide, is there is another kind of testing method which is called as a PCR DNA, in the peripheral blood monocyte, PBMC, which is called as a PCR DNA test. This we do mainly for babies who are born to positive mothers, so you can start to detect the DNA. So what we are looking in the PCR DNA test is the genetic piece of the virus itself. We are looking for the piece of the virus itself. So by that way, we can know the status of the baby and put that baby on certain corrective measures, which we are already doing it also in Zambia. And we use what is called a dry blood spot test. And this is why I did this. But otherwise, the rest of the graph is the same. The RNA, the antibody, and the P24 antigen testing. Okay, here it just shows only antigen. But if you see the test kit, it has got both markers, both antigen and antibodies. And this is a bit disturbing. If you see for an adult, the viral load peaks up. Can you see the CTL, which is the cytotoxic T cell response, is robust and the viral load declines, which is good for an adult. But for children, invariably their immune reconstruction and their immune system is not robust like an adult. You find that the viral load still continues to be high and the CTL response is delayed. It's very slow. This is what, it's a sad occurrence for a child. But then again, due to initiation of highly active antiviral therapy, the child can have a full life. This is one of the questions, when the audience was asking, drying. The viral transmission is in around 24 hours. We are talking of fresh blood and high viral load concentration, and it doesn't last too long. And by heating, you can see around 30 minutes, 10% bleach or 70% alcohol, again the virus doesn't survive. And pH extremes, pH 6 is highly acidic and pH 10 is highly alkaline. So the neutral pH is 7, which you can even see in your mineral water bottle, 7, which is the hydrogen ion concentration. So the pH extreme also doesn't allow the virus to survive. Now this one is a study which was done after 5 years after infection with HIV. You see almost 62% of the people have got a high set point. And you see, it's not that everybody reaches a high set point. Some people who are long-term non-progressors, they've got lower set points somewhere in this category. Less than 8% of them, they have a very low threshold. Some people, they have got a higher set point, meaning after reaching a high peak viremia, the viral load comes down to what is called as a set point. A person can remain with the set point maybe for 7 years, 8 years, 9 years, can remain on that same set point. But the fact of the matter is, they can easily pass on the virus to their partner because the viral load is high. So, and also, their chances of starting to, again, for the viral load to go up is also much earlier. Maybe in around 6 to 7 years, this person could start to have a higher viral load, meaning the immune system will fail to function. And someone with a lower set point could take much longer than this person who is on the top line here. And so the statistical odds are in favor. And if you test HIV positive and if you are in advanced stage, and you will find that you will suffer from several opportunity infections and also the virus taking its foothold after crossing what is called the blood-brain barrier. And also the road to recovery is very slow. And this is one which we already talked about. There are some slight situations where there can be false positive and false negative results. False positive is having a cross antibody reactions. HLA means it's a human leukocyte antigen. So, and multiple transfusion of blood, recent influenza, and of course there can be some laboratory errors. And false negative, if you're newly infected, you're say only 2 weeks into the window period and you go and get tested, that can be a false positive. And advanced, this is something very interesting. This is one I wanted to. Can you see advanced HIV infections? If someone is almost with a very low CD4 T helper cell count, almost at the last stage of HIV, that person will not have detectable antibodies. You see, immune response are 2 things. One is the cytotoxic T cell response, which is the CD8, and the other one is the antibody response. So, in order for the general, suppose I am the general, who is the general here? CD4 T helper cell is the general. I don't go and fight the battle. I give the instructions to the CD8 cytotoxic T cell to go and destroy infected cells, like probably a macrophage, which is a phagocytic cell, probably infected, it is destroyed. Or simultaneously, also I will also trigger an antibody response to bind to free virus particles, and that can flag for other cells like cytotoxic T cell to come and destroy. So this is something which can be also observed in some very rare cases. And sometimes the testing kit has got only HIV-1 and probably the person has got HIV-2. Okay. And then there's something very interesting here.